Thank you so much. And it's a real pleasure for me to be able to talk about rate and rhythm control for atrial fibrillation. Things have changed a bit since I gave this talk last year, and so you'll be getting the 2012 update version. So over the next 20 minutes or so, I hope to highlight the advantages and disadvantages of rate versus rhythm control in patients with atrial fibrillation, review options for control of ventricular rate in patients with atrial fibrillation, and then describe options for rhythm control. Now, Dr. Goldhaber covered some of this already, but this is a growing problem in the United States, atrial fibrillation, and we know that the prevalence actually increases as our population gets older. And we see that climb, although it's more noticeable in men, is actually true for both men and women. The projected number of adults with atrial fibrillation in the U.S. is actually going to double from 2010 to 2040. And we'll have about 5 million U.S. adults living with atrial fibrillation by 2040. Now, Dr. Goldhaber taught us a little bit about the terminology, but I want to review that because it's important for some of the trials that deal with rate and rhythm control. So, lone atrial fibrillation describes this rhythm in the absence of structural heart disease. Paroxysmal atrial fibrillation describes episodic atrial fibrillation where the episodes terminate spontaneously somewhere between 24 hours and 7 days. Persistent atrial fibrillation describes atrial fibrillation that fails to self-terminate within 7 days, and then permanent atrial fibrillation lasts for more than a year, and cardioversion has failed or has not been attempted. Atrial fibrillation has major consequences. Loss of organized atrial contraction can contribute to exercise intolerance and even heart failure. The rapid ventricular rate further causes a decrease in exercise tolerance, can contribute to heart failure. For patients that have coronary artery disease, it can actually cause ischemia. And then if you have a fast ventricular rate for long enough, you can develop a tachycardia-induced cardiomyopathy. And then finally, much of the focus of today's proceedings is talking about the risk of stroke, which comes from left atrial and left atrial appendage thrombus. And you can have strokes and you can have systemic embolization related to atrial fibrillation. The rationale for a rate control strategy is to avoid the hemodynamic consequences of atrial fibrillation, but also to alleviate symptoms of palpitations, lightheadedness, shortness of breath, and chest pain, and also to prevent complications of heart failure and this tachycardia-mediated cardiomyopathy. The rationale behind rhythm control is very similar. We're trying to avoid hemodynamic instability, alleviate symptoms that remain despite adequate rate control, improve exercise capacity and quality of life, and then prevent complications of heart failure and cardiomyopathy. Now, the debate about rate control versus rhythm control has raged for decades, and actually the discussion continues. And I want to go through some of the clinical trial data and the logic behind this controversy. Prior to the publication of large randomized controlled trials, most clinicians taking care of patients with atrial fibrillation contended that rhythm control was preferred over rate control. It was thought that restoration and maintenance of sinus rhythm was believed to be the most effective means of controlling atrial fibrillation symptoms. Rate control itself does have some strengths and limitations. For its strengths, it improves rate-related symptoms, and it's effective at reducing the hemodynamic instability that comes from having a rapid ventricular rate. For limitations, patients can continue to remain symptomatic despite having adequate rate control. And as Dr. Goldhaber mentioned, as we get older, we develop some impairment of our left ventricle to fill, and we become very dependent on the atrium contracting and pushing blood into our ventricle. And as we lose that, we may be symptomatic from atrial fibrillation despite having rates that are very normal in the 60s for a ventricular rate. Furthermore, rate control doesn't reduce the risk of thromboembolism, and that's why it's so important to continue anticoagulation in these patients. For rhythm control, again, there are strengths and limitations. If you can maintain sinus rhythm, quality of life is thought to be improved, and it's effective for improving rate and rhythm-related symptoms. For limitations, unfortunately, as Dr. Goldhaber mentioned, many patients on rhythm control continue to experience atrial fibrillation, and they may not even know that they're having episodes of atrial fibrillation. Antiarrhythmic drugs don't come for free. They actually come with a lot of toxicities and can actually generate malignant heart rhythms that may be worse than the atrial fibrillation itself. And finally, rhythm control does not reduce the risk of thromboembolism. So now I'd like to go through at least 2 landmark clinical trials that have helped to reshape the way that we think about rate versus rhythm control. The first trial is the AFFIRM trial, which looked at patients with atrial fibrillation, about 4,000 patients, and randomized them either to a rate control strategy, which used common drugs like beta blockers, calcium channel blockers, and or digoxin, and compared that with a strategy of a rhythm control agent, which would be any type of antiarrhythmic agent. And here we can see for the endpoint of cumulative all-cause mortality, there was no significant difference in the 2 groups. Rhythm control and rate control had very similar cumulative mortality. And if we look carefully, although it wasn't significant, there's a trend to perhaps a lower mortality in the rate control group. Now, whenever we do these large randomized controlled trials, it's important to look at subgroups of the patient population to see if there are any groups that might behave in a way that's different than the general population. And what we see here is that for the most part, most patients showed similar finding where there was a trend towards better mortality in patients who used a rate control strategy. The only exception would be perhaps in patients younger than 65 and patients with heart failure. There might be a little bit of a trend towards rhythm control being better, but we will talk a little bit more about that in a moment. The RACE trial was another very important investigation looking at rate control versus rhythm control. This study looked at about 500 patients, again comparing a rate control with a beta blocker, calcium channel blocker, and or digoxin, and compared that with patients on an antiarrhythmic drug. And here we can see that there really was no difference in the primary endpoint, which was a composite, or any of these components of the primary endpoint. The only difference was that patients in the rhythm control group had a much higher rate of severe adverse drug events related to their antiarrhythmic therapy. And when we looked at event-free survival, again, we didn't see any significant difference comparing rate control with rhythm control, but again, perhaps a trend towards better survival with rate control. There have been some other trials, smaller, looking at rate versus rhythm control. In the PF trial, they looked at diltiazem versus a very common antiarrhythmic drug, amiodarone, and they found no significant difference in quality of life, but for some reason the patients on amiodarone had a much more frequent tendency to be hospitalized for adverse drug events. In the STAFF trial, they looked at a rate control strategy versus rhythm control and cardioversion, and again, they were not able to show any difference in quality of life, but there was an increased rate of hospitalization for patients getting the antiarrhythmic drug. And finally, in the Hot Cafe trial, you've got to love cardiology clinical trial names, they looked again at rate control versus cardioversion and rhythm control. And there was actually a trend in this study towards greater mortality and more thromboembolic events in patients who were receiving rhythm control. Now, one of the subgroups that we saw in the AFFIRM trial that we thought might do better with a rhythm control strategy was patients with heart failure. But this very important paper from the New England Journal actually showed that when you looked at patients who had atrial fibrillation and heart failure, there was really no difference in survival when you looked at the rate control group and the rhythm control group. These lines are essentially superimposable. We've learned some very important lessons about anticoagulation from the AFFIRM and RACE trials. It's important to note that in both of these trials, if you were in the rhythm control group, anticoagulation could be stopped if sinus rhythm was maintained for at least a month with antiarrhythmic therapy. In the rate control group, you were locked in to receiving anticoagulation by the protocol. And when we look at adverse events in the AFFIRM trial, we can see that there's really no significant difference in the rate of stroke or systemic embolism in either of the two groups. But what's really important is if you look at this after discontinuation of warfarin row, there's actually a numerically higher rate of stroke in patients who were in the rhythm control arm who stopped anticoagulation. And when we looked at the RACE trial, we actually see a similar effect where thromboembolic complications are not really different between the rate and rhythm control. But there might be a trend towards higher rate in the rhythm control group. There are some limitations to these very important clinical trials. The mean age of both studies was approximately 70 years. A younger, healthier population might benefit more from an aggressive rhythm control strategy. Frequency of atrial fibrillation is an important consideration. 50% of patients in the AFFIRM trial had symptomatic atrial fibrillation for less than once per month. And AFFIRM results may not be generalizable to patients who experience more frequent symptomatic atrial fibrillation. There's a mortality paradox that's noticed. Antiarrhythmic therapy was associated with a 50% increase in non-cardiovascular mortality in the AFFIRM trial. But if you looked at patients who were able to maintain sinus rhythm, there was actually a 50% improvement in survival in the AFFIRM trial. It's thought perhaps that rhythm control might be beneficial and might be better than rate control if we had safer drugs available. Now I want to spend a little bit more time talking specifically about rate control. So who are the ideal candidates for rate control? Well, in general, patients who have atrial fibrillation for longer than a year, patients who have increased left atrial diameter or dimension, patients with paroxysmal atrial fibrillation of short duration, those with underlying medical causes for atrial fibrillation that haven't been treated, and then those with sinus or AV node dysfunction tend to do better with rate control. And the logic here is that a lot of patients with these clinical characteristics have a very low likelihood of converting to sinus rhythm and maintaining sinus rhythm because many of these factors actually contribute to a continual tendency to develop atrial fibrillation. Beta blockers are a very common class of agent used for rate control. They receive a class 1 recommendation for rate control in patients with atrial fibrillation. For the most part, they appear to have similar efficacy. They should be administered at a frequency that prevents breakthrough tachycardia, and they're preferred in patients who have heart failure and left ventricular dysfunction. Similarly, calcium channel blockers are very important for rate control in atrial fibrillation, also receiving a class 1 recommendation. They can be preferred over beta blockers in patients who have reactive airway disease, bronchospasm, emphysema, and they should be used with caution in patients who have left ventricular dysfunction. Digoxin is recommended for rate control in atrial fibrillation patients who have left ventricular dysfunction, and that's a class 1 recommendation. But it can also be added to help achieve better rate control in patients that are on beta blockers and calcium channel blockers, and that's given a class 2A recommendation. The mechanism of action for digoxin is thought to be a reduction in ventricular rate by increasing vagal tone to the AV node. It's important to note that both mechanistically and in our clinical experience, digoxin doesn't always work well for patients who have very high adrenergic tone. There have been proposed guidelines for how you should achieve rate control in patients with atrial fibrillation. Some of these recommendations are to maintain the resting heart rate less than or equal to 80 beats per minute on a 24-hour heart monitor, to keep the average heart rate equal to or less than 100 beats per minute, and to make sure that no heart rate is greater than 110% of the age-predicted maximum. And then finally, to keep the heart rate less than or equal to 110 beats per minute with moderate exercise. Now, there have been studies looking at whether strict rate control provides any benefit over a good, honest effort at rate control, but not meticulously increasing the medications to achieve these numbers. And there really hasn't been a difference. You actually might make patients more symptomatic if you make them hypotensive by aggressively pushing beta blockers and calcium channel blockers. Shifting gears to rhythm control. The ideal candidates for rhythm control include those with persistent symptoms despite rate control, those with inability to maintain adequate rate control, patients who present with a first episode of atrial fibrillation, very young and very elderly patients, and then patients with symptoms of heart failure or left ventricular dysfunction. Now, we'll note that those last two categories are highlighted because they're somewhat controversial. Pill in the pocket is a particular strategy for rhythm control that allows patients to self-administer an oral dose of an antiarrhythmic agent when they develop symptoms of atrial fibrillation. And this strategy receives a class 2A recommendation. In general, propofenone and flecainide are the most commonly and most rigorously evaluated antiarrhythmic drugs for this strategy. Patients considered for a pill-in-the-pocket approach should be maintained on a rate control agent and shouldn't have evidence of structural heart disease or conduction system abnormalities. Here are some data that were published in the New England Journal. The pill-in-the-pocket approach can be very effective, cutting emergency department visits in half and then keeping the atrial fibrillation symptom duration to less than or equal to 6 hours in most patients. Adverse events are relatively low with this type of antiarrhythmic therapy. Now, last year when I spoke about this subject, dronedarone had a lot of popularity in the medical literature and people were very enthusiastic. It's amazing what a difference a year makes, and I'll talk a little bit about that. Dronedarone has similar antiarrhythmic effects to amiodarone, but it has some key structural differences that have been believed to reduce the frequency of long-term complications that are associated with amiodarone. I should caution that dronedarone should be avoided in patients with decompensated heart failure or New York Heart Association class 4 heart failure and permanent atrial fibrillation. So both amiodarone and dronedarone are designer molecules, but they've made some key changes in dronedarone that are supposed to correlate with the lower incidence of adverse events. These iodine moieties have been removed, and that's thought to help make dronedarone less toxic to the thyroid gland. And then they've added a methylsulfonamide group to help make this drug less soluble in fat and to decrease neurotoxic effects. When the Athena trial was published in the New England Journal, there was a great deal of enthusiasm for dronedarone because these outcomes were quite important. For the outcome of hospitalization or death from any cause, there was a significant reduction in patients assigned to the dronedarone group compared with the placebo group. When we looked at death from cardiovascular causes, there was also a significant reduction in patients assigned to the dronedarone group, and there was a similar reduction in hospitalization due to cardiovascular events. But in the Palace trial, they studied dronedarone versus placebo in high-risk permanent atrial fibrillation patients. And here, when you look at the endpoint of stroke, myocardial infarction, systemic embolism, or cardiovascular death, there was a very important increased signal in these events in patients receiving dronedarone. And when you looked at cardiovascular hospitalization or death, again, you see a higher incidence of that in patients taking dronedarone. To top it off, the FDA has put an important warning about severe liver injury associated with the use of dronedarone. And because of these emerging data and this warning, we've really seen not much enthusiasm for dronedarone in the last year. The 2011 American College of Cardiology, American Heart Association, and Heart Rhythm Society guidelines have important suggestions on picking antiarrhythmic drugs. In particular, they ask the clinician to consider the patient's comorbid conditions when trying to select an effective antiarrhythmic drug. It's important to know if your patients have no heart disease, hypertension, coronary artery disease, or heart failure, because that has implication on the agent that you would pick. It's common to use rhythm control agents in conjunction with cardioversion. It's thought that this will increase the likelihood of successful cardioversion, reduce the energy requirement for cardioversion, decrease the rate of early return of atrial fibrillation after cardioversion, and help maintain sinus rhythm after a successful cardioversion. Now, cardioversion has been traditionally thought to be a very benign intervention, but in this important study published in Circulation, one of the largest collection of cardioversion patients, you'll note that actually the rate of stroke and systemic embolism after cardioversion is not trivial, and it's important to keep in mind when we plan for cardioversion in our patients. Now, one other important method for rhythm control is actually growing in our utilization, and that's atrial fibrillation ablation. And I'd like to spend some time talking about that. Now, atrial fibrillation ablation can be performed with radiofrequency ablation or cryoablation, and we can see here that the rate of adverse events from this procedure is actually reasonably low. When we look at major atrial fibrillation events, the effect of atrial fibrillation ablation is much greater than that of antiarrhythmic drugs. Here we see that the freedom from atrial fibrillation is much greater in patients who undergo AFib ablation compared with patients treated with antiarrhythmic drugs. In the Cabana pilot study, of which there's a bigger randomized trial being conducted, they evaluated antiarrhythmic drugs versus ablation for persistent atrial fibrillation. And we saw here a 59% improvement in freedom from atrial fibrillation in patients who underwent AFib ablation. To describe a little bit about what this procedure entails, this is performed through venous access, puncture of a vein with catheters that are passed up into the right atrium. Then they puncture the interatrial septum and cross over into the left atrium where they perform the ablation. The focus of the ablation is to isolate the pulmonary veins from the left atrium, because it's thought that actually much of the impetus to develop atrial fibrillation actually develops from the pulmonary veins and electrical activity that is present in those pulmonary veins. Now, atrial fibrillation ablation does have complications. There is an incidence of cardiac tamponade, pulmonary vein stenosis. When they actually do the ablation, they make burns along the pulmonary veins, and you can get a very vigorous stenosis or narrowing of the pulmonary veins that can present clinical problems after the ablation. There's also a risk of vascular complications and esophageal injury with AFib ablation, but in general, a well-tolerated procedure. So well tolerated, in fact, that the 2011 American College of Cardiology, AHA, and Heart Rhythm Society guidelines have really elevated atrial fibrillation ablation to a premier spot in the therapy for AFib. They give a class 1 recommendation for patients who have significantly symptomatic paroxysmal atrial fibrillation and who have failed treatment with an antiarrhythmic drug and have normal or mildly dilated left atria, normally or mildly reduced left ventricular function, and no severe pulmonary disease. It gives a 2A recommendation for patients with symptomatic persistent atrial fibrillation, and then a 2B recommendation for patients with symptomatic paroxysmal atrial fibrillation who have very large left atria or more significant left ventricular dysfunction. So the overall approach for rate and rhythm control is first to treat precipitants, because no matter which method you choose, whether it's rate control or rhythm control, if you haven't addressed the reason that the patient has atrial fibrillation, it's going to be very hard to achieve either adequate rate control or rhythm control. Anticoagulation is still key because, as we learned, a simple strategy of rate control or rhythm control isn't going to prevent thromboembolic complications. In general, most patients start with a rate control strategy, and then rhythm control is instituted to control symptoms. For patients that don't have successful control of their symptoms in rhythm control, then advanced therapies like ablations can be considered. I'd like to end with a few take-home points. Based on data from large randomized controlled trials, the majority of atrial fibrillation patients should begin with a rate control strategy. A rhythm control strategy can be considered in patients who fail rate control, elderly patients, those with heart failure, and those presenting with an initial episode of atrial fibrillation. Regardless of whether rate or rhythm control is selected, anticoagulation remains an important component of therapy because we need still to prevent stroke and systemic embolization. And with that, I'd be delighted to take questions.